Hello, my name is Tom Stinchcombe. I work at Duke Cancer Institute in Durham, North Carolina. I'm a thoracic oncologist who specializes in clinical care as well as clinical trials for patients with thoracic malignancies. We're all very intrigued by the integration of palliative care to our patients with advanced non-small cell lung cancer or extensive stage small cell lung cancer. I think we've had some challenges in which patients should be referred, which patients are going to benefit from the most from this referral. And so I think this was largely driven by a trial by Dr. Temmel, where she took patients with advanced lung cancer. Patients got routine care, or they got routine care plus palliative care. And they found that patients who had palliative care in addition to routine care lived longer, had a better quality of life, and less symptoms. And so I think most of us looked at this as like, we need to do this. We need to integrate this. I think the challenge has been one, the patient perception when they hear palliative care, that it obviously has an ominous overtone, and we've had to spend some time educating our patients and educating ourselves that no, this is really just to optimize your symptom control. They help us, help you, and get rid of some of the stigma around palliative care. I think personally, I've also found that, for some of our patients with an oncogenic driver get a TKI, they respond greatly. They're going to be doing well for years. The benefit for the palliative care as a group may be less in those patients because the therapy is so effective and so effective at reducing symptoms. I try and refer patients who have a very high symptom burden. Patients who have symptoms such as pain, nausea, that I've attempted to control and failed, and I needed additional assistance in order to get this problem addressed, are some of the symptom-directed aspects of this. And I think also there's some patients who really are very informed about palliative care and want one to be integrated as well. And so that's another driver of integration of palliative care. I think some of the challenges that we faced is palliative care varies from center to center, from a location to location. Some centers have board certified care doctors available to them routinely. Other centers have a different model of palliative care in terms of what's provided. I've also think that sometimes the palliative care, we don't have enough providers, and so sometimes patients still sort of gravitate to us rather than to their palliative care provider for some issues, just because they're seeing us anyway for the chemotherapy, immunotherapy, other aspects. And so I think how to coordinate the care has been a little bit of a challenge. I think the other thing that we found as we try to do this is if you implement the palliative care too late, you reduce the yield of it. And so some people wait until the symptoms are so bad and the prognosis is so poor, and the patient didn't really benefit. And I think that's the other hazard that we have to be aware of is, just as there's an error in referring too early, there's an error in referring too late. And so we really got to kind of work on what is the best time to do this. I know that some of the palliative care groups, at least our group, have moved to telehealth as a result of the COVID-19. And I think that this may actually be advantageous for this type of service. Because many times prior to COVID-19, patients would see me, they'd have to wait around to see the palliative care, or for that matter, the inverse sequence. Now, if they come and see me and they can do the telehealth visit with the palliative care doctor on a different day or something like that, there's a little bit more flexibility in the schedule, and we might be able to improve the care delivery model.